Good afternoon, everyone. Thank you for making time to come to this very important session on access to key harm reduction interventions in prison, challenges and opportunities. My name is Fariba Soltani, and I'm the chief of the HIV/AIDS section of UNODC. I'm based in Vienna. And as a part of our work, we are responsible for working among people who use drugs to prevent HIV, hepatitis, TB, and also health in prisons is a very big part of our work. So in this session, we'll explore the challenges faced by people who use drugs in prison settings, including access to harm reduction services, medical services, and the difficulties they encounter after release. We will also present opportunities to scale up these evidence-based interventions. Prisons are often overlooked in public health responses, yet they are high-risk environments where the prevalence of infectious diseases, including HIV and hepatitis, is significantly higher than in the general population. Unsafe drug use, tattooing, and unprotected sexual behaviors combined with overcrowding and limited access to healthcare makes people in prison especially vulnerable and one of the HIV key populations. However, prison settings are also present an opportunity to reach people who use drugs and who might not be easily accessed in the community. With the right harm reduction measures in place, like opioid agonist therapy, needle syringe programs, overdose prevention and management, and regular testing and treatment, we can not only improve individual health outcomes, but also advance broader public health. Despite strong evidence and clear guidance, many of these services remain under-implemented or absent altogether in prison systems. Today's session will help us explore both the challenges and opportunities to change that. We were supposed to have 3 excellent speakers, but unfortunately Yanina couldn't join the conference, so we have 2 excellent speakers lined up for today. Our first speaker is Marcela Jofre, presenting the global state of harm reduction in prisons, access and main barriers. She'll be followed by Christophe, who is presenting life after prison, challenges and goals for formerly incarcerated persons on opioid agonist treatment. Each presentation will last around 15-20 minutes. Now that we only have 2, you have more time. And we will reserve some time for having some questions and answers at the end. And if we have time, I will also present a little bit about the work that we are doing in UNODC. So without further ado, I would like to give the floor to Marcela, a criminal lawyer and human rights analyst with the Human Rights and Justice team at Harm Reduction International. Marcela holds a master's in criminal law and master's in human rights and politics from the London School of Economics. She'll be presenting key findings from the Global State of Harm Reduction's 2024 prison chapter, focusing on access gaps and systematic barriers to harm reduction for people in prisons. Marcela, please.
Thank you. Thank you so much, Fariba. Hello, everyone. I'm Marcela Jofre from Harm Reduction International, and today I will provide a global picture of the situation of availability of harm reduction services in prisons and main barriers identified by our study, The Global State of Harm Reduction. So today, my presentation will be in English, but if you would like to access the slide in Spanish, you can do it so by scanning, by scanning that QR code there that will lead you to the PDF version in Spanish. Because I tried to make it Spanish in English and in this presentation, but yeah, I'm not a designer, so it was quite difficult. Yeah, so firstly, the QR code? Yeah, sure. It's not going back. There. You're welcome. can I? Okay. So Okay, so firstly, I'd like to draw your attention to the profound impact of punitive drug policies in our global system. These policies have become a primary catalyst for incarceration and prison overcrowding globally. So let's consider this. Over 11 million people are currently behind bars across the globe. And it estimated that over 20% of people in prisons are there because of drug offenses. And the cases, sometimes, many cases, are predominantly related to drug use and drug possession. So we are talking really about minor drug offenses. And the situation is even worse in some in some regions of the world, including Latin America and Asia. And women are disproportionately impacted. In Latin America alone, between 35% and 70% of women in prison are there because of drug offenses. And this is only conviction. We are not even talking about pretrial detention, which the situation is even worse. And the majority of prisons are overcrowded worldwide, with only 30% of prison system in the world working within capacity. So the enforcement of these policies had led to an alarming overrepresentation of marginalized and racialized groups within criminal justice system. People with history of drug use are significantly overrepresented in prison population. Estimates suggest that between 1/3 to half of all individuals entering prison have history of drug use. And estimates also indicate that 90% of people who inject drugs will be incarcerated at some point of their lives. So while incarceration may reduce drug injection in some cases, those who continue injecting drugs in prison do that in a very unsafe conditions, and also drug pattern changes within prison. So the provision of harm reduction in prison is central to achieving UNAIDS' goal of ending HIV by 2030 and meeting sustainable development goals. However, global median of HIV prevalence reported among people in prison in 2023 was almost double that of the general population. Over 50% of people in prison globally are living with hepatitis C, and 5% are living with chronic hepatitis B. This is sources from UNAIDS. So we can see here that the lack of harm reduction combined with high-risk behavior, like sharing syringes in unsafe condition, and dramatically increase the transmission of HIV and other infection diseases. And this situation is further exacerbated by poor prison conditions, overcrowding, inadequate access to health services, peer pressure to use drugs, and generally lack of access to health and lack of protection of human rights. And this leads me to the next slide. So we know that UNODC, UNAIDS, WHO have consistently advocated for the implementation of comprehensive harm reduction services in all prison. And these services include needle and syringe program, opioid agonist therapy, and naloxone. But what I wanted to highlight here is that harm reduction is not only about public health, it's also about human rights. And I want to be very clear with this. Apart from the rights restricted by a judicial sentence, people deprived of liberty retain all their human rights. And because of the situation of incarceration, a state have a heightened duty of care and have the responsibility to protect the right to health of people deprived of liberty. With me. So despite all this obligation that can translate in the obligation to guarantee accessibility, availability, acceptability, and quality of harm reduction interventions in prison, The Global Stable Harm Reduction have identified that there's been little progress in the provision of harm reduction services in prison, and people deprived of liberty remain severely underserved by harm reduction interventions. So we can see here, when it comes to OET, here you can see a map with dark blue showing the countries where OET is available in both the community and prisons. And OET is available in at least one prison in 60 countries compared to 93 in the community. And you can see in the map that most of the countries that provide at least one prison-based OET program are in Western Europe with 21 countries and Eurasia with 19 countries. In contrast, fewer countries offer OET in prisons in the Middle East and North Africa, in Asia, Oceania, only New Zealand, Australia, and only in Eastern and Southern Africa, only 4 countries. And Puerto Rico offers the only prison-based OET program in Latin America and the Caribbean, and there is no known OET in prisons in West and Central Africa. And in countries where OET is available in at least one prison, coverage is still a problem and varies significantly between prisons and even within facilities sometimes. And receiving OET while in prison is crucial for reducing death among people who use drugs for 6 months after release, both all causes of death, but also overdose. And unfortunately, the situation is not any better when it comes to needle and syringing programs. A needle and syringing program is available in at least one prison in 11 countries compared to 93 in the community. 2 more than in 2022, when 9 countries provided needle and syringing programs in prison. The new countries providing needle and syringing programs since 2022 are Iran, North Macedonia, and Ukraine. But needle and syringing programs are not longer available in Armenia. And we also know that France provide needle and syringing programs in Montpellier. I don't know if some of you were to the workshop, and we could hear from Fari, his experience, who is the person who has been running that program for many, many years. But that program is an unsanctioned program that is operating without the formal approval from the government, so we can't count it in the data. But we really appreciate Fadi's work. And again, we can see the concentration of these programs apart from Canada and Iran. All identified needle and syringing programs in prisons are in Eurasia. So moving into take-home naloxone available on release in at least one prison. The Global Stable Harm Reduction identified only 11 countries, mostly in Europe, that provide take-home naloxone available on release. However, again, the coverage can vary between countries, but also between their prisons. So in some places, for example, they require a prescription to access take-home naloxone. And within prison, in many cases, naloxone tends to only be administered by staff, by prison staff, which is a problem because that can limit the effectiveness since the staff is not always available and immediately at reach when overdose situation is happening, which can be the big difference between life and death. And drug consumption rooms. The Global Stable Harm Reduction has identified only Canada as the country that provide a prison-based drug consumption room. Compared to 18 countries, we have drug consumption room in the community. So again, making harm reduction services available in prison, that not necessarily means that they are fully accessible to all. There is still many, many barriers that we have identified to accessing these services in prison. So the first barrier identified is barrier to starting services in prison. So in some countries, OAT in prison is limited to people who were prescribed OAT before incarceration. So this is the case in some Eurasian countries, including Albania, Bulgaria, Latvia, Montenegro, Serbia, and similar restrictions apply in Lebanon and Mauritius. And when OAT is available to everyone, like regardless if they have been prescribed OAT before entering to prison, there is still some barriers to starting the programs in prison, such as waiting list. So some people have to wait months to start OAT in prison. So another barrier identified, which is actually identified as the most common barrier by the survey responded by our report, is the risk or perceived risk of sanctions or loss of right and privilege in prison. So, for example, in Romania, when someone enters a drug treatment program, they are reportedly declared unfit to work while in prison, which means they will lose their income and cannot participate in meaningful activities. Also, in England and Scotland, service users have reported that while people who disclose use heroin on admission to prison are offered help, those who disclose it later, once they are already in prison, are met primarily with punitive responses and are often suspected of selling drugs or engaging in other illicit activities in prison which violate prison rules. And then they fear that this will damage their prospect of accessing, for example, early release or parole. And similar situation is found in Indonesia, where research found that people participating in OAT programs in prison were perceived by both prison staff and peers to be engaged in illicit drug use. They were heavily stigmatized. They've been seen as lazy, poor, dirty, unproductive, and also presumed to have HIV. And this multi-layer discrimination affected not only the access to these services, but also their mental health and their access to, again, parole or early release. Sorry, okay. So the next barrier is the lack of confidentiality and anonymity. Sorry, it's a hard word for me. So we know that a state should ensure that all health services are provided under the basis of voluntary, informed and free consent with complete confidentiality of any medical condition, treatment, healthcare access by people in prison, which includes, of course, access to harm reduction services, intervention, HIV treatment, and treatment for any medical condition, really. But our report also identified that this can be a barrier. For example, in Moldova, uptake of OAT is believed to be limited by confidentiality breaches, as well as a stigma and prison subculture that informally regulates the access to these services. So those who accept methadone treatment are frequently subject to bullying, isolation, and which is directed by leaders among the prison population. We also identified some barriers that specifically affect women. Women who go to prison often have complex circumstances, history of trauma, higher level of mental health issues and needs, including drug dependence and treatment. And UN Bangkok rules, for example, require specialized treatment programs in prison that are designed for women with substance dependence, and taking into account the prior victimization, the special need of pregnant women, for example, women with children, as well as like services that are gender sensitive and consider also their cultural background. However, our report also identified that prison-based harm reduction services that exist, the few that exist, are concentrated in men's facility. For example, in Moldova, the only therapeutic community in prison is in a male facility, and the 2 prisons in Ireland that have consultant-led enriched drug dependent services are only accommodate men. We also reported by our Global State of Harm Reduction that, for example, in Eastern and Southern Africa, civil society have documented widespread barriers to accessing HIV testing and treatment in prison for women who use drugs, including in humiliating and punitive treatment by prison staff. And so that, of course, becomes a barrier to accessing these services. And the situation is also similar in other countries, such as Belarus. And trans and gender diverse people also face many barriers, similar to the one I've already mentioned. But also, trans and gender diverse people in prison, usually in some cases, are held in long periods of locked up or solitary confinement, often under the grounds of protection. And of course, this limited the access of all services in prison, including harm reduction. So scaling up and sustainability of services, I think this is something, a barrier like transversal to all harm reductions nowadays. But most of harm reduction services rely on donor funding and support. So national scale up and linkages to national HIV and public health programs are key to ensure equity across prison and between prison and the community. And incorporation into state budgets ensure the sustainability of these programs. And I want to give here like 2 examples. Romania, the NSP and OAT and prevention programs for group that were provided were funded by Global Fund. And once the Global Fund ended, the government wasn't able to take over and sustain and finance these services. So most of them had to stop. On the contrary, we have a positive example of Moldova. Moldova have a similar situation where the Global Fund was financing these services, but they started offering harm reduction services in 2000 through this international and technical assistance. But over the years, they managed to transition and develop a supported regulatory environment and started funding services from the state budget, and also had been expanding these services lately. So yeah, here's a good news at least. Yeah, no, it's not everything negative. So yeah, well, other barriers that I'm not go like in depth, but is of course the continuity of care upon release, because one thing is what can we offer, what should be offered to people in prison, but again, another very key element is the continuity of care and the provision of those services once people are released from prison. Other barriers identified are the management of harm reduction in prison by prison staff and medical staff, and the delivery of services, and of course the quality of them. Yeah, so just to conclude, I just wanted to highlight that to address the problems of prison system, we need a drug policy reform that decriminalizes drug use and applied health and human rights center approach and evidence responses. Harm reduction is an essential element to the right to health, including for people deprived of liberty. But we've seen, and it should be available and accessible to all people in prison in at least at the same standard than in the community. However, we've seen here that little development had been observed, and people in prison remain severely underserved by harm reduction intervention. So there is an urgent need to maintain and scale up harm reduction services for all, addressing the barriers and challenges identified, including stigma and discrimination. And the last thing is, if you want to know more about it, you can go to our website and find out more in our global state of harm reduction and our briefing on human rights standard on access to harm reduction in prison. That's it.
Thank you very much, Marcela, for that very informative presentation on the state of prison harm reduction in prisons. And as you mentioned, there has been very small step forward, but really not enough to address the issues that we have. And the most important thing that you mentioned is that we don't need to have so many people in prison. And in many countries where we actually, when I go on mission and we talk to prison officials, they come to us and say, you know, how can you help us with the overcrowding? This is the main problem in our country. And what we promote is alternatives to incarceration. There is no need to put people in prisons, and this reduces a lot of harm that is caused by incarcerating and putting people in prisons. So that's the number one, there is no need. But if people are in prisons, to expand the harm reduction services and also ensure the quality services are available for both men and for women, because for women the situation is even worse, and we need to really look into it. So thank you very much. You mentioned really very important issues. So next we have Christophe, a researcher at University Institute of Addictions and adjunct professor at Université de Montréal. Christophe's presentation will explore the experiences of people who live in Quebec prisons and their navigation of OAT post-release. Thank you, Christophe. Please.
Thanks, and I will take the pointer. Yes. Perfect. So, hi everyone. Just to say that I'm not the only one presenting, and I'm with Louis-Philippe Lowe here. I'm going to also present you. So Louis-Philippe is a PhD student who has conducted all of the interviews. So if he was not here, I would not look as smart without the data that he actually collected. And he's doing actually his thesis about the perception of harm reduction among correctional officers, but you will hear more about his results in the next editions of HRI. So so we will continue, so I will pass the mic to.
All right, thank you, Christophe. I cannot stay seated while I present. Hi, so I'm Louis-Philippe. Today's presentation is titled Life After Prison, Challenges and Goals of Formerly Incarcerated Persons on Opioid Agonist Treatment. 2 years ago, we were at Melbourne. We were presenting the first phase of our study. It was interviews with inmates inside the prison. So we looked at barriers and facilitators inside the prison, access to OAT. Now today we're going to present to you the final results of our study. We did interviews after. Okay, so you probably know all this, but just so we're on the same level, I'm going to present it to you real quick. What is OAT? It's a treatment for people who has opioid use disorder. It comes in 3 forms in Canadian federal prisons. First, you have the first one to have come along is methadone. It's generally a liquid mixed with juice. that you have to take once a day, every day, I mean. And it allows to continue to use opioids at the same time. And there are a lot of side effects to it. So then came Suboxone. Suboxone is a tablet or a film or a little cartoon that you take orally and you have to take every day. It aims to cease completely the opioid use, and there's much less side effects than methadone. And the next one, which has been only available for the last 5 years in Canada, in prisons, is a Sublocade. So it's an injection into the abdomen, and it makes a little bump, and it's a slow release buprenorphine. So you have to get the injection every month. So it's less like come and go to the pharmacy and everything. And aside from the burn that you have while getting the injection, there are not so much side effects. So the Correctional Service of Canada provides OAT has provided OAT for over 20 years. As you can see here, the most popular is Suboxone. Methadone, because of the side effects, has lost its popularity. Just to show you here, OAT over the years, from December 2018 to December 2024, the number of inmates on OAT has gone up and the wait list has gone down because the Correctional Service of Canada thinks it has a lot of benefits for the inmates, so we're grateful for that. OAT in correctional settings is linked to improve outcome post-release, as you can see here. The main one is reducing poisoning overdose. But OAT in itself is not sufficient. You have to be well prepared when you are released from prison, and you have to have a follow-up like the following days, even the following hours after you are released, or you don't have these good outcomes. So this is a model from Jofre and colleagues. It says that some people receive OAT in prison, and once they leave, they live stigma, discrimination, unstable housing, unstable jobs, unstable relation. They go back to their peer who uses drugs, and they go back into this life. And for all of these reasons, some of them interrupt OAT, which is not a good thing, because when you are on OAT for a long period of time, you lose your tolerance to opiates. So when you do opiates, you have increased risk of overdose. That being said, our study, the final phase, was to explore the experiences of Quebec former inmates with opioid use disorders receiving OAT. So basically what we wanted to know was what was their life like after they got out of jail. Are they still on OAT or not, and why? And did they go back to substance use or not, or why? And if they have used other services and treatment other than OAT. So methods, we interviewed 22 participants at baseline interview. This is just about the 10 participants that I was able to reach for a second time. So because of reincarceration, because of some broke conditions, 3 no-show, 2 refusal, 1 unreachable. For all of these reasons, we were able to reach out to 10 participants out of 22. And the inclusion criteria are there, so to be under the responsibility of Correctional Service of Canada, to have OUD, and it was 2 to 6 months after release, because we wanted to know what the release was like, and stable and continuous participation on OAT while incarcerated. So this is what I just told you, but in autumn 2022, I did the baseline interview in prison, and then there was the release date, and I waited 2 months to 6 months in the spring and summer of 2023 to interview the people again, to do a follow-up. It was qualitative analysis. All interviews were audio recorded, and our other colleague did the transcription. We identified principal themes and elements. It was inductive and deductive interpretation because we had, like, prior to the interviews, we had like specific thematics in mind, but we let them come in as the interviews flowed. And it was an ongoing discussions between me and Christophe for several months. All right, so I'm gonna let Christophe present the results.
Yeah, I'm going to stand up also because just saying half of the slide, it doesn't help. So it's true. So it works. Yeah. So from the qualitative analysis, we flesh out 3 main themes, and each of those themes are actually one life goal that participants had. So we're going to present them as if they are 3 distinct goals, but they're actually very interconnected and intertwined. So I'm going to use this. Okay, it's done. So the first theme is, and the first goal is about to reintegrate a normal life. And I put a normal life as a code because it depends on the person. And for them, when they say a normal life, it's to have a job, to have a place to stay, to have all of their official documents, it's to have leisure activities. So that's what they consider as going back to a normal life. And we can see that they are actually facilitators and barriers, but they can go on different levels. So it can, some of the facilitators or barriers belongs to the person's individual, others are related to the community, and then again the institution, and here's mainly the health providers and the correctional services that are involved. So if we look at the individual level, we see that there are certain psychological trait and state that can facilitate or be a barrier, but the same trait can be different according to the person. For example, confidence can be seen as a good psychological state for some people, but for others it's going to be a bad trait, and Louis-Philippe is going to explain this later with an excerpt. And many of them, they say that they're going to try to keep focus on their goals, and they're going to do self-monitoring on their behaviors, but at the same time they say they have all of those plans before going out into the community, but they don't know what is going to happen. So sometimes they get overwhelmed with emotions, with everything that is happening. And then they have this, some of them have the innate impulsiveness. So they realize that they may have laid out all the plan, but it's not going to happen the way they thought it's going to happen. Then in terms of community, they said, obviously we know that emotional support is very important, but what they underline is that they need practical, pragmatic support. That means having someone to drive them around if they don't have a car or a license, is to have people helping them with the paperwork, because there's a lot of them when you get out. It's to have your social insurance number again, your medical card. It's to have to find a house, how to find a job. All of these takes a lot of time, a lot of energy, and if you have been out of the system, it's very complicated to just understand what is happening. So this is a kind of support they really need. And obviously, they try to stay in an environment where there's not a lot of drugs and lack of criminal influence. But they say that since they have been out of prison, the big problem is that the label sticks with them. So they just feel that the community just reminds them, you were an ex-criminal, you were an ex-user of opioids. And they just feel that they try to turn the page to go on another chapter, but it's not what is happening. And also they say that if the institution helps them to guide them through the whole process of having the papers, it's going to help them a lot. So it's just not because they get out of prison that the case is over. They need to have a transfer of all of the paperwork from prison to outside to ensure that the reintegration is going well. And so I'm going to...
And since it's qualitative studies, we're going to present to you a few quotes from the participants that illustrate what Christophe was telling. So the first one, that's the story of my life. When I'm too high, when things are going too well, it can be dangerous too. It's not when things were going badly that it was dangerous. It was when things were going too well. So as Christophe said, confidence can be a great thing. It can be a facilitator to maintain OAT, but overconfidence can also be a barrier to OAT. Next one is, I stole from people, and you know people talk. I'm afraid of being labeled. Then, when I got out, well, I was afraid it would come back to haunt me. So, as Christophe said, it's not because you don't use opioids, it's not because you are not in prison anymore that it's gone. It's like it follows you for the next several months, several years. And the next quote is, I got out, then I was taken care of here in the halfway house. They explained the rules to me in full. He explained to me what he expected of me in the community. Then I told him what I expected to do too. After that, well, I relaxed, I took my time, I wasn't stressed. So this is a positive experience that highlights the importance to prepare the release and to have a follow-up in the community, in the halfway houses.
So one second goal, which is also a second theme that they had, was they tried to move away from substance use because they considered that being in prison, because most of them were in prison for drug-related offenses, convictions. So that's why they say, okay, I'm going to move away from this, at least for a moment. And so one of the motivation for that is that they have the feeling that they have the chance to start a new life. So they say that if I put drugs away for a while, maybe I will be able to have the job, the house, and everything that I consider as a life that I wanted. So that's what they say, I'm not taking any drugs. And they also have the feeling that since they are taking OAT, it's not compatible that much. But at the same time, they do feel that it's been their whole life for some of them, so it's very hard to get rid of things that are considered part of your identity, the people that you met, your friends, the context. So some of them call them, I will be an addicted person, quote unquote, the rest of my life. So it's very hard to get rid of this. So how can I be another person if drug is not there anymore? And in terms of substance, what's very interesting is that they say that OAT for them is also a drug, it's a treatment. So what should I do? Should I continue or not? Considering that if I want to stay clear of all drugs, I should also stop OAT, which is a drug. So, so the perception of what is a drug, and should we really stop? Should we just diminish, reduce consumption? Is also a thing that has to be a talk with the person. So it's not a black and white. It's not you stop or you continue. We should find a middle ground for all this. And also for many of them, they said they had a lot of fun when they were taking drugs. It has pleasant effect. We use drugs for a reason for millennia. And for them, it's like, I want to feel that again, so I'm not ready yet to take drugs, but maybe I would take, for example, cannabis or something, another drug that would help me feel, to elevate my mind, but not have the problems that I had before that landed me in prison. In terms of community, they have the feeling that they really have to move away from contexts that remind them from drug use, but they said it's very difficult because when they get out of the prison, most of the jobs they can find is either in construction, in restaurants, and a lot of people are actually, drugs are very omnipresent in those workplaces. So they say it's hard. I'm trying to have a job, but that drug is everywhere. I want to stay away from drugs, so what do I do? Should I just quit my job? But where do I go afterwards? And they say, but for some of them, they stop using drugs because they've been told to, because they have release conditions. So if they have been caught, even with cannabis, which is legal in Canada, they can go back into prison. So it's not a personal motivation to stay away from drugs. It's because they actually want to stay out of prison, among anything else.
And here are a few quotes again. First one is, I was tired of being tired. When you're in the business, things happen all the time. Bad luck happens all the time. You can get busted at any time. You can fall apart. You can lose your life. So we felt that the participants were like almost traumatized about their past experience, about always being anxious about what was going to happen. Will I lose everything? Will I get arrested by the police? The second one is, what's next is that I don't feel like using that much. If I didn't have Suboxone right now, I would have probably taken the speed that was giving to me. I would have frozen the emotion. So it helps me maintain an emotional stability. That means I wouldn't get involved in anything. So by this quote, you can understand that the person is honest with himself, because well, he knows that he relies on OAT to not go back to drugs. If he stopped OAT, then he would go back. And the third one is, I meet them, you know. Here, there are a lot of junkies. There's a lot of heroin. I see that and I find them pathetic. Well, me, in any case, I don't want to get involved in that again. I don't want to know anything about it. So, like, they want to turn the page. They want to move. They want to move to something else, to another life.
And we also see from that last quote that the stigma is not only from what they receive from others, but how they integrate the stigma. They self-stigmatize themselves, which is also a problem. Okay, I will continue. So the last theme is to continue accessing OAT and other services. So why they stay on OAT after being released, that they said it actually helped them to control their opioid use. It helped them to achieve the different goals that we talk about. They are very satisfied with the treatment. But at the same time, they have the feeling that it's a crutch, it's a burden to go there every day, to take, in the case of methadone and Suboxone. And they say that being on OAT means that they do have a drug problem. So again, we go back with the self-stigma, the perception that they are ashamed, they are embarrassed to have this treatment because it reminds them of that label that people are put on them, and then they integrate that label. Also, OAT in itself, the molecule, can be either a facilitator and a barrier, but this is true for any kind of drugs, any kind of medication that you take. If you have positive effects, for example, it helps you to have better concentration, to sleep better. If you don't have any strong negative side effects, you tend to stay on the treatment. If you have very bad side effects, if it doesn't work, if you have other medication and goes into pharmacological interaction, then you may put OAT aside for the other medication that you're taking. Also, for some of them, they want to continue taking other drugs. So mixing OAT and other drugs sometimes doesn't work well for them. So it's a balance. They have to choose. And in terms of institution on why do they stay or why do they leave, is that if the correctional service plan everything in advance, that they make contact with the pharmacy outside, that they have a prescription of 3-4 months, so the person has enough time to find a physician to renew the prescription. All of these will help to have the pharmacies, the health providers, the correctional services, that they talk to each other, that they handle the case together. It helps for them to continue the treatment, because otherwise what they feel like is like there are many actors around them that do not talk to each other. They have to repeat the same story. They have conflicting information that they receive from different parts. So they want a coherence between the different actors. And they say that it's very complicated. In Quebec, it's very complicated in general, the health system. But people don't know which door they have to knock. They don't know who they need to talk to. What is the process? Which paper document they have to fill? It's a hassle. And for someone that has been out of the system, going through all this, and this is just a way you have to think about finding a job again, housing, all that stuff. So for them, they are just overwhelmed with almost everything.
And last few quotes. The first person was talking about disclosing his OAT to his employer. So, but I told lies, you know, that I'd already had an accident, I had a surgery, then I had trouble with opioids. No, I didn't say that I was into drugs and all that. No. So you can feel like the resistance from the people. It's a medical treatment, but it's not considered as one, like as diabetes or other treatment. Like the person was afraid to talk to his boss because he was afraid of the consequences it might have. The next one is about receiving Sublocade. It's only when they give it to you, but you get a fucking burn. Hold on to your hat. It's not something just minor. Well, I'm fed up. I took it anyway the last month, but this month it's clear I'm not taking it. So for some OAT medication like methadone and Sublocade, the side effects are too intense, so the people want to disrupt the treatment just because of the side effects. And the last one is quite touching. I went to pharmacies that were always spotting you. The guy, he practically followed you into the pharmacy, you know, because you were on methadone. You were a criminal or you were a drug addict, so automatically, you know, you're going to rob them. So, as you can see, there's a lot of stigma, discrimination, and it's supposed, like Marcela said earlier, it's supposed to be confidential, it's supposed to be anonymous, but like things like that happen. And yeah, it's quite terrible.
So yeah, we're going to wrap things up because I think you are ready for your happy hours. So basically, from what we gathered from the interviews, is that going back into the community is not only having OAT, it's all the different things that is happening. So we need to have a holistic vision to consider all the basic needs of the person. And what we should also consider that is that stigma is everywhere. That is among the institution, it's among the community, it's among the person itself. That's something that needs to be worked on for them to continue a treatment or to seek help. We also need to have conversation of them, what they consider as OAT. Is it a drug? Is it a treatment? What is the balance between the two? And also, community is very important to have support. And it's not, like I said, not only emotional support, but also practical, pragmatic support. A few limitations. So this is a Smurf that was always complaining. So this is my French roots. So it was a convenient sample that, so we only had 10 people that accepted our interviews, but we may have the happier version of what is the reality of things. And since, like Marcela said, we have a lot of men in prisons, and most of the services are geared towards men, so we don't know much about the realities of women, and less about people from the rainbow community or the indigenous community, but we do think that some of the results can be applied in a similar context as Canada. And finally, we hope that our result will help inform policies intervention and improve the lives of these individuals. So we thank you for your time. That's it.
Thank you.
Thank you very much, Louis-Philippe and Christophe. I'm sorry I didn't have you in the program to introduce you, but it's good that you... Yes, so thank you very much, really, for this amazing research that you're doing and all the really excellent results that you shared with us. And that your study reveals that life after prison focuses on rebuilding the stability, and the stigma, the discrimination, all this follows people. So again, we come back to the point that people should not be, especially for, you know, minor drug offenses or having possession, you know, for personal use, they should not be put in prison, because this follows them throughout their life in getting jobs later, studying, going to university, all sorts of things, and the stigma and the shame and all that follows people. So it's really not a good idea. And that we need to, you know, it's more, I mean, OAT is more than a medication. And I don't think any other medication has this weight with it. You know, people are on different treatments for, hypertension, for diabetes all their life, and nobody accuses them of, you ate badly, so, you have to be on blood sugar, medication. Nobody blames them. It's sort of accepted. But people who are on OAT, they have to be blamed all their life for one decision that they made or a life choice that they had at some point. So these are really very important elements. So thank you very much. Just before I give the floor for question and answer, as I said, I just want to give you a couple of points about, the work that we are doing. And something that you mentioned in the last slide was the parole officers and also involvement of law enforcement in the work we're doing. This is something, I think, the missing link for harm reduction and prison work in many countries is that we don't involve the law enforcement in the work. They're not sitting around the table when we are discussing how they can become a part of the response. Because we have the health people there, we have the drug control people there, and to change sort of drug policy, it takes many years and a lot of political commitment. But working with law enforcement, who are the first line responders, so when people are getting arrested, when something happens, they're there, but they never receive any training on what they should do, how they should respond. How can we, I was just in a session earlier on at lunchtime talking about gender-based violence, how to recognize gender-based violence, how can they address it? So this is an element of our work that is, it's very important, and I think this is what we should all engage when we're talking harm reduction, when we're talking reducing, prison population. We need to bring the law enforcement so they understand and not arrest people who have a small amount and really know where they can refer them for services. So this is one element that I think is very important. And we also have a comprehensive package, like we have a comprehensive package of addressing HIV amongst people who use drugs. For many years, we've had a comprehensive package of 15 interventions for people who are in prisons that we developed together with WHO, UNFPA, UNAIDS, ILO, and UNDP. And if countries implement this, and we're not just talking about harm reduction there, we're talking about HIV, sexual transmission, all HIV risks in prisons. So, and what Marcela just mentioned, I mean, the service coverage, the importance, countries tick the box. You mentioned many countries, they have one NSP program in one prison covering 20 people, or they have OAT in one prison that covers, 200 people max. They tick the box. They are included in the data that they have the services, but in all honesty, what services they're providing has no effect on the epidemic or what we're trying to do for reducing incidences of HIV or hepatitis. So we really must work to increase service coverage. Even when countries have tick the box, make sure that it is at a level that really makes an impact. So this is, I think, an important message that we need to take. And this year marks the 10th anniversary of the Nelson Mandela rules, and this you mentioned as well, which is an important tool for prison reform and human rights globally. So we really need to take this opportunity to advocate for work in prisons, especially on the occasion of the 10-year anniversary of the Nelson Mandela rules. And I hope that we can work, more constructively, comprehensively together on addressing all these issues, that harm reduction, prisons, law enforcement, they're all very intricately, connected, so that we can really gain success, especially in these times where the resources are so limited. We really need to be very focused on what we do and how we approach it. So thank you very much. Now I open the floor for any questions, please. If we can, yes, get ready for having more chats. So, yeah, If you can introduce yourself, please, before your question.
Thank you very much, all of you. Great presentations. My name is Bob Rousseau. I like to refer to myself as a gringo-lombiano. I lived 65 years in the States and this last 10 years here in Bogotá. I have a question for Marcela, and then I have a question pour les deux gentilshommes du Canada. Bien. So, ben oui, hein? So we'll start with Marcela. Here's my question. Ta-da. Are you aware of any educational programs that introduce prison administration, correctional officers, and prison staff to trauma-informed practices and harm reduction standards? It's my belief that little will change in prisons until the prison officials, correctional officers, and prison staff are educated to trauma-informed practices and harm reduction standards. So that's my question for you. Are you aware of any efforts being made anywhere globally that tries to educate the prison administration to trauma-informed practices and harm reduction standards?
Yeah, thank you for your question, because I think that's a very key element to really progress in the implementation of harm reduction services that really protects the life of people deprived of liberty. Because as Fariba mentioned, like, we cannot do real progress without involving prison staff, law enforcement, so on and so forth. So unfortunately, I'm not really aware of like any specific comprehensive program. I know there's been organizations, civil society trying to sensitize prison staff, prison administration, law enforcement in general on human rights and harm reduction services, but like implementation from government-run programs in prison, personally, I'm not aware of. But I think the national mechanism of prevention against torture can play a key role in doing that. They are key to monitor, to prevent torture, and for that, how the staff, the prison staff, is implementing or not implementing harm reduction services is key. We, on harm reduction many years ago, well, like here is Cinzia, who worked in that project. We elaborated a monitoring tool for national preventive mechanisms where they can monitor with a human rights focus how harm reduction services are implemented in prison and how prison staff is being involved in that work.
I just want to add that actually we have capacity building, programs for prisons, for health, which is our area of work, but we do huge, prison reform work that we work with prison officials. And one thing that is important, in the discussions, in the advocacy, is they have to see what's in it for them, to accept it and to really buy into it. And it needs to be bought into, when you talk harm reduction in prisons, at the senior level, at the management level, and also at the, prison guard level. So they need to see what's in it for them. So we have these different levels of training and discussion with the prison administration. As I say, we are focusing on the health, but we have colleagues who work on, more extensive prison reform work, because there's lots of issues that is not health related, but contributes to what we are doing. So it's important to talk about prison reform at a general, more base level.
Yes, yeah, this just came to my mind, but I mentioned that Ukraine started to implement needle and syringe programs, and I wanted to highlight because I think it can connect with your question. So the way they implemented this was in connection, in close partnership with a civil society organization, Free Zone. And to do this, I think it's a very interesting approach, because to do this, they first assess the needs and the interest of prison population to access these services. And once they have this in mind, when they have this information, they implemented the program and they trained prison staff, but they also trained peers. So now the programs incorporate peers that they can inform prison population about the access to needle and syringe programs, and then accompany them after release. So it's not the same, but I think it's something cool.
Has a similar system.
Well, that's the perfect leading for my question from my two friends from Canada. Have you guys heard of forensic peer specialists? In the state of Massachusetts and Philadelphia, these are ex-inmates who are educated and to go back into the prisons to work with prisoners prior to their release, to talk about issues of being stigmatized when they go back into the community, also about where they're going to live. They have a list of employers that accept ex-convicts, so they already have a step forward in finding employment. So this is a tremendous new resource that the forensic peer specialists are the new link between prisoners who are inmates who are going to be moving back into the community. So they work with them before they leave, and then they follow them for 2 years afterwards. So it's a tremendous program. If you'd like more information, just let me know. But do you have anything like that in Canada?
Actually, it's very difficult to answer because Canada is made of 10 provinces, and each province has its own way of functioning. And when we were talking with the Correctional Service of Canada, they said they tried to also the study that we did. They had to do the same thing in Ontario because they said the realities are very different. So and when I was doing the analysis, that's something that I was reading about, and I made the suggestion to the direction of the correctional services. I don't know if they're going to hear me, but the last time that I complained, they reached because in 2019 I was complaining that there were no guidelines about OAT, and I was a bit I was not very nice in my report. And somehow when I restarted that the study that you just heard, they had magically a guideline that appeared. So I was like, I hope that maybe they were going to change. But they said that I would say that as the years goes, in the recent years, the Correctional Service of Canada, they try to implement different types of harm reduction and initiative. And they do have now a trauma-informed education, but this is more for the inmates. They have also things that are specific for indigenous communities. So instead, they have what they I don't know how you said it in English, but this lissage. So it's the elders that are also present in prison to help them. So yeah, I don't know if you want to add something.
Well, about your first question, it's my subject of thesis, the correctional officer and harm reduction in prison, but I don't know yet. So stay tuned, come back in 2 years and I'll tell you about it. But I am under the impression that they have the minimum information about harm reduction in prison. Like they are told, well, you have to accompany the inmate to the centre de soins, the health center, and you have to like do a checkup, and like they are told what to do, but they are not told what the philosophy is, what the approach is. They are just being told you have to do this starting now. So that's my impression, but I'll tell you about it in 2 years.
Thanks. Well, hello to everybody. I'm Daniel. I'm from Bogotá. I come from National University of Colombia as a member of an academic group who invests about prisons, society, and peace construction. I was wondering if any of you have knowledge about harm reduction services in prison, of course, but related with other substances or another kind of substances, because I was wondering that here in Colombia we don't have any harm reduction services in prison, but we don't have the fentanyl crisis, right? We don't have a large use of injections. We don't have a lot of people who use drugs by injection. We have, but it's not that big. So I was wondering also, because here in Colombia we have in prisons and in the street other kind of substances, just like bazuco is the most famous, and marijuana or some alcohol derivatives, but I think that it's my question for all of you, if you can.
My question is in line with that. Can I add to it? Please. Okay. Yeah.
So thank you. But because I was thinking the same thing when we saw the map comparing countries that have harm reduction practices, they were very global north-centered harm reduction practices. And I think that many of us, I come from Mexico City, I work with the Mexico City government, I'm in charge of drug use prevention and addiction in Mexico City, and I'm coming looking for information about more stimulant use. There is injected stimulant use, but it's more smoked stimulant use. It's very high impact, in some cases, higher impact than injectable opioids, depending on the substance of the opioid. But so I think for a Harm Reduction International Conference, many, and not only this panel, have been very stuck on opiate injectable use, which I'm sorry is very 1980s. It's not that it's not important, but there's so much bigger conversation. And there's a reason why on that map, so many of our countries don't have OATs as our standard for harm reduction in prisons, because we don't need that specifically, you know? So I really think that for the conference, for the information, because the presentation from Harm Reduction International is really interesting, but it really only covers a very, very traditional form of understanding harm reduction. And I think coming to Colombia was really an opportunity to open the conversation to other realities of drug use and harm reduction. And I think we're really missing out on that conversation. And some of us really came looking for that conversation because it's urgent in our countries. And I just really want to add that the fact that I have to say this in English in Bogotá, because nobody in the audience has a translation, because they're assuming that the conference is in English and that they don't need to hear Spanish speakers speak in our own language when we want to comment, is also part of the feeling that this is a global north conversation that is taking place in Colombia, but that didn't really take into account where it's taking place. It just came to use this site because of all of the significance that it has, but it's not really dialoguing with Latin America for this being the first Latin American conference. And I think that we really need these conversations. We really need to talk about methamphetamine. We need to talk about bazuco. We need to talk about cocaine. There are a lot of harm reduction programs for all of this. Some of them we have in our prisons, no? And so if there are things that you know about, I think it would be great if the panel could share. And if not, I really hope that you can take this towards the organizers as a comment, a little bit of a disappointment in such an important international event, but that still really focuses on the global north, as harm reduction has done for way too long now. And I think it's time to change. Thank you.
Hola, buenas tardes. Yo soy el doctor Ángel González Carrasquillo, de Puerto Rico. Da la casualidad que esta I don't. Are you guys fluent in Spanish? Well, actually work with this kind of population. I've worked with them for the last few years. I'm part of a team with case managers, psychologists, all the support staff, and I just want to make a couple of points. Sublocade, it's very important. You know, it's my experience with. My patient's experience with sublocade is kind of it's not easy to support. It's very they hurt a lot, so they don't like it. At least the patients that I've had. The other thing is, if you don't give sublocade, comes in two doses, 300 milligrams and 100 milligrams. And the experience with my patients is that they have a protocol, like a standard protocol. They give you the first dose with 300 milligrams. If you do well, they don't keep it. They drop you down to 100 milligrams. You go into withdrawal, so it's not very happy. They're not very happy with that situation. The other thing that I wanted to express in terms of this population, they need a lot of support. And you need for the team to be very, very concerned with the harm reduction issues, because there's a lot of stigma in the staff. So that influences the whatever happens, the outcomes with these patients. I just wanted to mention that.
Hello, Carmen Albizu Garcia from Puerto Rico. We've been conducting studies in prisons since 2005, and one of the things that I wanted to ask you is about other issues of risk factors for hepatitis. We, in a study with a sample of representative sample of all persons sentenced to prisons in Puerto Rico, we found that when you control for injecting drug use in prison, and the prison system had undertaken hepatitis C testing in the whole prison population, and shared the information with all the persons that were affected. And in a study in which self-reported HCV by persons living in prison, we found that approximately 6 to 10% of the persons that reported hepatitis C were non-injectors, and they did engage in tattooing in prison. And tattooing in prison is very risky because they reuse equipment, and the tinctures can be contaminated, the injection equipment can be contaminated. So I really wonder if you have explored that, because that is something that really also merits attention. And then the other thing I did want to share is that when we used, that time it was DSM-4 diagnostic criteria in the survey conducted with the sample, and we included alcoholic use disorder and tobacco. And 85% of the persons, of our respondents, were cigarette smokers. And 36% had a lifetime history of alcohol drug abuse. Now, these are the two most dangerous recreational drugs, and the effects of them are not necessarily only due to how you consume it, but because the drug itself is dangerous. And so I also wonder whether in the harm reduction efforts conducted in the prison setting, we are paying attention to alcohol use disorders and to tobacco smoking. Thank you.
Some of the questions, and then we take the second round, because we might forget. Yes, please go ahead.
Yeah, so first I would tell that, we are sorry that we have been doing the whole thing that is very global north, and we acknowledge that we are in a global south setting, and I would love to share things that is happening that could improve your situation, what your context. But the problem is, I just realized that when I was working with the Correctional Service of Canada, it's been like 6 years. At the beginning, the reason they came to me was they were having opioid overdose. But before that, they were like, it's not happening. We're just closing our eyes or ears. It's not happening. With the research, it opened a door. So we started with opioids because we said, like, okay, that's what they want. And then when I was finishing the study, I was thinking the contract was over. And they were like, oh, are you interested in continuing the other projects? What should we work on? So now I said, there's other stuff than opioids. There are other problems. So now that's what I'm going to have a discussion this year. What should we now work? We have the possibility in Canada to do this. So we have a refill project, but we have other projects that we can. I'm open to ideas. So we have the funding to do that kind of research. So I'm hearing about stimulants that is specific for that. So yes, I'm going to take note and try to build something. And if you want to share contacts, I can try to make the best to have data, maybe in the next edition, that would be actually helpful for you. So that's my response. And like I said, they were, for example, the self-needle is not something that you find in every place in Canada. In Quebec, I think it's only one person that has two of them. It's not very one. And I think it's Juliette, if I'm not wrong. Yes, so it's the women's prison that has the self-surrender. So again, like I said, it took the OET, that project to start opening the conversation because we realized that they just were closing their eyes for many, many years. So we're just starting really to have conversation with the staff, with the services to know what can we do, what we should implement. But we are unfortunately at the beginning, while we are in a situation that looks like the 90s, but we're in 2024, but we're trying to move things forward. But we're sorry that it's going very slowly, but we're at least now that the door is open, we're going to go full in.
Thank you so much. The first thing I want to say is to apologize because we understood that there will be translation available. So I'm really sorry that that's been a problem. And because I am from Latin America as well, and the questions were from Latin American people, I now switched to Spanish because I think we need to show some respect to that. No podría estar más de acuerdo con lo que han dicho. Es verdad que toda la data que se ha mostrado y todos los avances que se han mostrado están más bien centrados en Europa, y eso obviamente responde porque hemos estado mirando a las intervenciones tradicionales de reducción de daños que no responden a la realidad latinoamericana porque los patrones de uso de drogas son distintos. Harm Reduction International es una organización que tiene sus orígenes en Liverpool por la crisis del VIH y que parte en el fondo con estas ideas. Pero progresivamente hemos entendido que también hay una necesidad de colonizar la discusión. Eso fue también parte de querer traer la discusión a Latinoamérica. Yo estoy muy de acuerdo que esto tiene muchas limitaciones y que todavía tenemos muchísimo que trabajar en ese aspecto, pero sí lo que me gustaría como resaltar son dos cosas. Frente a la pregunta de que si habían algunas intervenciones de reducción de daño respondiendo a la realidad carcelaria en Latinoamérica, las tradiciones, o sea, las tradicionales que hemos nombrado acá, no. Y tampoco hay ningún servicio, yo diría, que no sea basado en la abstinencia. Entonces, me estoy refiriendo a que, claro, no hay de estos servicios que nombran acá, pero tampoco, lo que yo he visto al menos en la realidad chilena, no hay tampoco otras alternativas que no sean con un enfoque basado en la abstinencia. Entonces ahí yo respondería no hay, porque un enfoque basado en la abstinencia no responde a una aproximación de reducción de daño. Entonces, sí, yo creo que acá hay mucho que avanzar y si bien las respuestas tradicionales de reducción de daños pueden no ser aplicables a la realidad latinoamericana, creo que sí la aproximación de la reducción de daños es aplicable. Y ya eso es lo que tenemos que tratar de mirar, a tratar de implementar respuestas que vayan más allá de la abstinencia, que reconozcan la agencia de los individuos, que protejan la salud de las personas, más allá de la respuesta sanitaria, ¿no? Y yo ahí también estoy súper de acuerdo, que encuentro que a esta discusión sobre reducción de daños, Latinoamérica tiene muchísimo que aportar. Latinoamérica ha logrado poner una visión más interseccional a la discusión de la reducción de daños y a la política de droga, más enfocada en derechos humanos y mirando mucho más allá de la respuesta sanitaria. Así que yo espero que esta conferencia, esta discusión, estas nuevas voces también contribuyan a que más adelante vayan existiendo nuevas investigaciones, nueva data que permita también mostrar nuevas innovaciones en ese aspecto. Eso.
Thank you. I didn't understand the word, but I'm sure it was very... So I wanted to add that we have training packages on harm reduction for stimulant use that we have developed together with the International Network of People Who Use Drugs. So we have harm reduction, interventions for stimulant, drugs, cocaine. There are 3 different parts to this capacity building package. So you can, look it up and use it. And in the package that I just mentioned, of interventions for prisons, all this is included. It's harm reduction, but it's not only harm reduction in the classical sense. We're talking about condoms, we're talking about tattooing, and Cynthia knows better than me because she was also very much involved in this. So, and I mean, one of the experiences that I have personally with tattooing was in Romania when we started the program. This was one of the biggest problems for HIV infection. And what we did to overcome it, we brought a professional tattooist to the prison twice a week, and they would make appointments and do it in a safe way. So this is something from the experience, but we have these packages and we are working on harm reduction, not just for opioids, but for stimulants, because we know that this is a very important part, chemsex, all this that goes together with stimulant drugs. So thank you. I think we have 2 more.
Yes, I am. I'm supposed to say it's after 6 o'clock. I'm just flagging that, so I'm not sure what the panel would like to do, if they should come and speak maybe to you directly.
If it's very quick, I think the panel will take the questions.
Sorry about that.
I just had a quick comment and then a quick question. So my comment was about the suggestion that our next step should be to go to the police and really try to connect with the police. Because the police are the foot soldiers of the drug war, I'm not sure if this is the best step. And in my mind, the police shouldn't have any involvement in mental health or substance use stuff at all. And our efforts and our energy would be better put into getting the police out of mental health and substance use rather than trying to help them continue to do it. And I imagine what you're going to say to me is, we could work on that, but right now they're still doing it, and so we should sort of harm reduction it and make it better. And I'm speaking as somebody who I have trained the police. I've gone and done workshops with the police and all that. And I think one of the challenges is that they often take what we bring to them and twist it to make it dangerous for the people that we're trying to help. I think naloxone is a really good example, where the police are given naloxone, and now you see cops faking overdoses and then having their partners naloxone them and then really they're just having a panic attack, right? But they're given naloxone, and they magically come back, and then they're saying, like, oh, look, the naloxone fixed this horrible overdose this police officer had after looking at looking at fentanyl. We've also seen police officers using naloxone as a way to torture people, like, oh, just like put a bunch of them up his nose, like, who cares what happens afterwards? I've also talked to police about trauma-informed care, and like, maybe don't kill a person who's in a mental health crisis, who's holding a butter knife. And I'll say, in this instance, this is a real thing. We had been with that person for 3 hours before you guys showed up. So why are we okay for 3 hours with this person, but the second you show up, you pull out a gun and then a taser? But their response to me is, that's our policy, and officer safety always comes first. So I just don't see that as the best way forward. Yeah. Then my question was for the gentleman from Canada. I'm also from Canada. So you mentioned a couple times about how internalized stigma and shame are a huge issue for when people are released. But I'm wondering kind of what are you doing to address that, or what are you kind of suggesting to address that, especially within OAT being an abstinence-only system and program? There's kind of this cognitive dissonance that occurs when you're like, don't be ashamed of your drug use, but I'm going to urine test you, and if you use, I'm going to take things away from you. It kind of reminds me of our government that keeps saying, this is a health issue, not a criminal issue, but we're going to keep it criminalized, so the police keep being in charge of it. It's like, then people are confused, like, well, it's not really a health issue then, is it? You're just kind of saying that. And even, you mentioned one person who, their drug use sent them to jail. Like, in my mind, it's the drug war and criminalization that sent them to jail, not their drug use at all. So I'm wondering, like, what are you recommending moving forward to address that kind of stigma and internalized stigma and shame within a world that is stigmatizing and shaming, and also within like abstinence-based systems?
I would try to find a quick answer for that. Actually, there's no answer on how do we resolve stigma in general in a quick manner, but I think that we have to open that conversation to have realize that the different people that are involved, how they can be, what is stigma, and how stigma hurts people, and just education just is the first step. It's not going to resolve everything fast, obviously, but I think that they need to realize that they do have internalized stigma, and how do they feel that, how they should work with it. So that's why psychosocial service should be also alongside, and not just health services, to just the perception of drug use, the perception of treatment, and the perception of stigma.
Thank you very much. Thanks for the interest. Thank you to the brilliant panelists. And we hope to continue this discussion with you, as there is so much interest. Thank you. Have a nice evening.